Hello, everyone, and welcome to our module on Parkinson's disease. Parkinson's disease is a neurologic condition that's related to the basal ganglia. And if you have not already watched the video on the basal ganglia, I highly recommend doing that before you watch this video on Parkinson's disease. The cause of Parkinson's disease is a loss of dopaminergic neurons, which means neurons that produce dopamine that are found in the basal ganglia. Specifically, it's neurons from the substantia nigra pars compacta, which is a portion of the basal ganglia found in the midbrain. It's shown on this image right here. That's where the dopamine-producing neurons are lost. When this happens, the indirect pathway of the basal ganglia becomes dominant. And once again, this is something I talk about in the video on the basal ganglia. This leads to the thalamus underactivating the cortex. And when you don't get activation of the motor cortex, you get hypokinesia or decreased movement. And that's the problem in Parkinson's disease, hypokinesia. So in the video on the basal ganglia, I talk about various disorders related to the basal ganglia. And in that video, I mentioned that Parkinson's disease is the classic example of a hypokinetic disorder. The reason there is hypokinesia or decreased movement in Parkinson's disease is because the thalamus is not activating the motor cortex like it should. And as a result, you don't get motor movement. In other words, you get hypokinesis. And the reason the thalamus isn't activating the cortex is because it's being over-inhibited by the globus pallidus. And the reason the globus pallidus is over-inhibiting the thalamus is because you've lost those dopamine-producing neurons. And so once again, I go through all this in detail in the basal ganglia video, but the problem in Parkinson's disease is reduced excitatory input to the motor cortex to drive movement. When you examine brain tissue from patients who have Parkinson's disease, there are two classic pathology findings, so let's talk about those now. These pathology findings are found in the surviving neurons of the substantia nigra. The first classic finding is depigmentation, so those dopaminergic neurons contain melanin, and you have fewer of them in Parkinson's disease, so therefore this region of the brain where the substantia nigra is, in the midbrain, is less pigmented compared to normal. Second classic pathology finding is the presence of Lewy bodies. This is the pathologic hallmark of Parkinson's disease. This image on the slide right here shows two Lewy bodies inside of neurons. This is one right here that I'm circling with my pen. This is another one right here. They are inclusions in the cytoplasm of neurons, intracytoplasmic inclusions. They're round and eosinophilic, which means they're pink staining. And they're made up of misfolded aggregates of a protein called alpha-synuclein. Okay, so now that we understand what's happening in the basal ganglia and the brain of patients with Parkinson's disease, I'm going to talk about the clinical features of this disorder. And the first thing you have to understand is that the diagnosis of Parkinson's disease is a clinical diagnosis. Usually no imaging or special studies are required. In order to make the diagnosis, the patient has to have classic features. There can't be a plausible alternative diagnosis besides Parkinson's disease. And then finally, the response to therapy is often an important part of diagnosing Parkinson. If you give patients the meds that treat this disorder, which we'll talk about later, and that improves their symptoms, that also helps to make the diagnosis of Parkinson's disease. Okay, so shown on this slide is a drawing of a man who has all the classic features of Parkinson's disease. We'll go through each of these features in the next few slides. First of all, notice that this picture is of an older man. Parkinson's disease usually occurs in patients over 60, although not always. And one of the most common features that you will see is a tremor, which means a shaking of the hand. Tremor in Parkinson's disease usually involves the hand, and the hand will tremble or have a tremor at rest that improves with movement. These are classic features of the Parkinsonian tremor. If the tremor doesn't have these features, it can be due to other things, which I talk about in other videos. The tremor is described as a pill-rolling tremor. So what does this mean? This means that the patient's thumb and fingers often come together as if they're rolling a pill between the thumb and the fingers. And as I said, tremor involving the hand is a classic feature of Parkinson's disease. It's often the presenting feature that leads to the patient getting the diagnosis. The second classic feature is bradykinesia, which means a generalized slowness of movement. When you meet patients with Parkinson's disease, one of the things that will stand out to you is that they simply move very slowly in all ways, walking, moving their hands, everything. So some of the things that can be evidence of bradykinesia are listed on the slide. So difficulty buttoning clothes or tying shoes. That's because it's very slow for them to make these fine motor movements. Patients can drag their legs. They take short shuffling steps. In general, what patients will tell you is because of the bradykinesia, they have a feeling of unsteadiness, and patients with Parkinson's disease are prone to falls. In terms of walking and moving, the problem usually gets better with exercise. So as patients exercise more, they get more neurologic activity in the brain, and that sometimes stimulates movement. So it's often a problem getting started moving. That's the bradykinesia. Not so much a problem maintaining movement once patients get going. Okay, the third classic feature of Parkinson's disease is rigidity. This means a resistance to passive movement of joints. It's usually best felt when an examiner passively moves the patient's limb. Classically, the rigidity is easiest to detect at the wrist or at the elbow. So, for example, if you take the wrist of a patient with Parkinson's disease and you move it for them, in other words, passively you move that joint, that's how you can detect the rigidity of joints associated with Parkinson's disease. There are two types of rigidity that you can see. One is called lead pipe. This is when there's resistance throughout the passive movement. The other type is called cogwheel rigidity. This is sometimes described as ratchet-like resistance. So this is best appreciated at the wrist. If you examine a patient with Parkinson's disease and you passively rotate their wrist, there will be resistance to movement, and then it will go away and you will easily move their joint. This is relaxation. And so this phenomenon is called cogwheel rigidity, and this is what happens in regions of the body where there's a tremor superimposed on increased muscle tone. And so that's usually at the wrist because, as we saw earlier, patients with Parkinson's disease usually have a tremor of the hand. And so when you move the wrist, you get that cogwheel rigidity. You can also sometimes appreciate it at the elbow. Okay, some other features of Parkinson's disease are shown in this slide. So one is masked facial expression. This is caused by a lack of movement in facial expression. That's what's shown in this man right here. If you search this up online or if you meet patients with Parkinson's disease, the expression on their face will jump out at you. It is very stiff and they don't move their muscles very often as they speak or look at you. Another classic feature is a shuffling gait. So patients with Parkinson's disease, remember, they have trouble initiating movement. So they tend to have a narrow-based gait. They take short steps and they often freeze as they try and move their limbs. Because of Parkinson affecting the joints of the hands and wrists, these patients have small handwriting. This is called micrographia. So if you ask the patient to write their name, the classic finding in Parkinson's disease is that they will start writing letters at normal size, but as they write more letters, the letters will become tiny, crowded, and hard to read. This is called micrographia, classic feature of Parkinson's disease. And then finally, there is a dementia associated with Parkinson's disease. This is usually a late finding that occurs after the patient has had Parkinson's disease for many years. And I'll talk a little more about this at the end of this video. Okay, now what I'm going to do is talk about the treatments of Parkinson's disease. Notice that I don't have a slide on diagnostic imaging studies or things like that because there really aren't any for Parkinson's disease. As I said earlier, it's usually a clinical diagnosis. Once you've made the diagnosis, you start treatments, and there are a number of drug treatments for Parkinson's disease. Most of them increase dopamine activity to try and overcome that absence of dopamine production by neurons in the basal ganglia. There are four major types of drugs used to boost dopamine activity in the basal ganglia. They're all listed on this slide. We're going to go through each of these in the next couple of slides. Okay, the first treatment for Parkinson's disease we're going to talk about is the combination drug carbidopa-levodopa. It goes by the trade name Sinemet. So this drug has two components. One's called carbidopa, the other is called levodopa. What levodopa does, which is also known as L-dopa, is it crosses the blood-brain barrier, and once it gets into the central nervous system, it's converted to dopamine by the enzyme dopa decarboxylase. And this boosts dopamine activity in the basal ganglia and improves symptoms of Parkinson's disease. The problem is there's also an enzyme found outside the brain, a peripheral version of decarboxylase that breaks down L-dopa before it reaches the central nervous system. This, first of all, limits the benefit of levodopa because less of it reaches the brain, but also you get more peripheral dopamine, and this causes side effects, which we'll talk about in a minute. So because of this peripheral decarboxylase enzyme, levodopa is always given together with carbidopa. Carbidopa is a drug that inhibits the peripheral decarboxylase, and it allows more of the drug to reach the brain. And so that's what's shown in this image on the slide here. If you give a big dose of levodopa, what will happen is some of it will be lost to metabolism in the GI tract, and then a lot of it will be lost to peripheral tissues because it's broken down by peripheral decarboxylase, and only a very little bit of it will reach the brain. When you give levodopa together with carbidopa, you blunt a lot of this peripheral conversion and more of it reaches the brain. The major adverse effect of carbidopa-levodopa is called the on-off phenomena, so let's go through that now. So the idea behind the on-off phenomenon is that healthy neurons in the basal ganglia store and regulate dopamine release. But as Parkinson's disease progresses, you have depletion of these dopaminergic neurons that are storing and releasing dopamine. This means you lose the buffering ability when you administer carbidopa-levodopa. So what do I mean by that? Well, without the ability of neurons to store some of the dopamine and then release it later, what happens is when you give a dose of levodopa, you spike dopamine activity in the central nervous system. This can be good for eliminating the symptoms of Parkinson's disease, but sometimes it becomes excessive, and patients get movement symptoms called dyskinesia, which I'll talk about in a second. But then beyond this, without some buffering from healthy neurons, the dopamine activity rapidly falls a few hours after a dose of levodopa. Basically, there's less natural dopamine around, less storage of any dopamine made from the levodopa drug, and as a result, when the dopamine levels drop, bradykinesia returns. And so this is called the on-off phenomena, and it's what happens when patients take carbidopa, levodopa for many, many years. Their Parkinson's disease progresses, and they start to develop this on-off phenomenon. To make this clear, let's look at this image on the slide. So over here on the left is a graph of a patient with early Parkinson's disease who still has some healthy neurons that can buffer dopamine levels. So if you give a dose of levodopa, this is the clinical effect on the y-axis, and the patient gets above the threshold for a response to the drug, but they don't have too much of a response so that they get dyskinesia. And as a result, because of those healthy neurons buffering the effects of levodopa, you get a nice sustained 4, 5, 6 hour period where you're getting the benefits of the drug without too much benefit leading to dyskinesia. Now over here on the right, we have a patient with advanced Parkinson's disease. So when you give the levodopa, the level spikes really high and it causes dyskinesia. And then the level falls really rapid and the patient goes back to having symptoms. And you only have this brief period in the middle where they're getting the benefit of the drug. And so that's the on-off phenomenon. It's not so much a problem in early Parkinson's disease. It's a problem as the disease becomes more advanced. So just to make this very clear, patients with the on-off phenomena develop on and off symptoms. So the on symptoms occur shortly after taking the medication. Their Parkinson's disease symptoms improve, but they can see excessive dopamine effects. These effects are called dyskinesia. It refers to involuntary movements. And this is obviously an unwanted effect of carbidopa, levodopa. This type of problem, dyskinesia, is more common in younger patients, and we'll talk about this later, but young patients with Parkinson's disease are often not treated with carbidopa because they commonly develop dyskinesia, the on symptoms. But then a few hours after the on symptoms, patients develop the off symptoms. This usually occurs 3 to 4 hours later. The drug wears off, their gait starts to freeze, and they get a return of Parkinson's disease symptoms. And so this right here is the on-off phenomenon. It occurs in patients with Parkinson's who take carbidopa, levodopa as their Parkinson's disease progresses. Other adverse effects of carbidopa, levodopa have to do with peripheral dopamine. So even though carbidopa inhibits peripheral decarboxylase, you still get some breakdown of levodopa into dopamine peripherally, and this leads to the adverse effects listed on this slide. So first of all, patients can develop nausea and vomiting from dopamine effects on the chemotherapy trigger zone, which is a part of the brain I talk about in other videos. You can see orthostatic hypotension from dopamine causing peripheral vasodilation. It's rare, but patients can develop cardiac arrhythmias from dopamine increasing the heart rate. And then the dopamine that gets created from levodopa in the central nervous system also causes some adverse effects of this drug. So some patients develop somnolence. This is from central dopamine receptor activation. It's rare, but patients can develop hallucinations too, also from central dopamine receptor activation. Okay, so carbidopa, levodopa is the mainstay of treating Parkinson's disease in older patients. It's usually the first drug that's started. But as we've seen, its effects start to wane as the disease progresses. And so when that happens, other drugs are added to carbidopa, levodopa to try and boost dopamine levels. And one of the classes of drugs that can be added are the so-called COMT inhibitors. There are 2 drugs in this group. The first one is called entacapone. The second one is called tolcapone. And they're called COMT inhibitors because they inhibit the enzyme catechol-methyltransferase, or COMT, an enzyme that breaks down levodopa. So if you look at this diagram on the slide here, this tells you everything you need to know about the drugs used to treat Parkinson's disease. So right here in the middle is levodopa, which, as we've talked about, can cross the blood-brain barrier and become dopamine, which is helpful for Parkinson's disease. But it's broken down by peripheral dopa decarboxylase, and that's why it's always given together with carbidopa to inhibit this. But levodopa can also be broken down peripherally by COMT, and so these 2 drugs inhibit that breakdown to try and drive more levodopa into the central nervous system. There's also a version of COMT found in the central nervous system which can break down dopamine there, and that's inhibited by tolcapone. And so the key point here is that these COMT inhibitor drugs are only used in combination with levodopa. They only make sense in a patient already taking levodopa, carbidopa, but when that drug starts to wane in effectiveness, you can add one of these drugs to boost the levodopa effects and try to prevent those off periods in terms of the on-off phenomenon. And as you can see in this slide on the screen, entacapone inhibits the peripheral COMT enzyme and tolcapone inhibits the peripheral and the central COMT enzyme. The major adverse effect of these drugs is stimulation, and that's because they boost dopamine activity. So they can cause patients to feel very awake and have trouble sleeping. Sometimes patients feel agitated. Tolcapone's been associated with hepatotoxicity, so it has to be used carefully in patients with advanced liver disease. And then finally, both of these drugs can turn the urine orange because of their metabolism. This is harmless. Patients will ask about this. Okay, our next group of drugs that can be added to carbidopa-levodopa are the MAOB inhibitors. There are two drugs in this group, selegiline and rasagiline. Both of these drugs inhibit the enzyme monoamine oxidase type B, or MAOB. This is an enzyme found in the central nervous system in the brain that breaks down dopamine and also serotonin to some degree. And so once again, if we look at our little biochemistry drawing here, we've got dopamine in the central nervous system. MAOB can break that down. But if you block MAOB with these drugs, that will boost dopamine levels. These drugs are often added to carbidopa-levodopa, although they can be used alone to try and boost naturally occurring dopamine levels in the basal ganglia. And most of their side effects are things that we talked about before related to dopamine effects, things like nausea and vomiting, hypotension, and excessive daytime sleepiness. There are two special side effects of these drugs that are very rare, but you need to be aware of them for board exams. The first is that these drugs can lead to the serotonin syndrome. Remember that MAOB breaks down serotonin to some degree, so it will boost serotonin levels. And so if a patient takes one of these drugs together with another serotonin-boosting drug like an SSRI antidepressant, that can lead to excessive levels of serotonin in the brain, and that's called the serotonin syndrome. Patients present with confusion, fever, and myoclonus, and I talk about this syndrome in detail in other videos. Another even more very rare effect that you can see with these drugs is the so-called cheese effect. This refers to a hypertensive crisis associated with any drug that inhibits MAO enzymes in the brain. So there are certain foods we eat that contain a substance called tyramine. Red wine contains a lot of tyramine, so does aged cheese, so does aged meat. And any MAO inhibitor, one of these drugs or some of the other MAO inhibitors used for depression, they block the breakdown of tyramine. And so if you block the breakdown of tyramine, the tyramine levels can go way up. Tyramine can cause hypertension. So it's very rare, but MAOB type inhibitors, if a person is taking one of these and eats a lot of red wine or cheese or aged meat, they can present to the hospital with a hypertensive crisis. This is called the cheese effect. It's much better described with the MAO inhibitors that used to be used for depression, but it is a very rare possibility in patients taking selegiline and rasagiline, although it's very rare at the typical dose range. Okay, our next group of drugs used to treat Parkinson's disease are the dopamine receptor agonist drugs. There are three important drugs in this group: pramipexole, ropinirole, and retigitine. If you look at our biochemistry drawing over here, these drugs can directly bind to dopamine receptors and activate them. They don't require L-DOPA or any of these other things down at the bottom of this image. So these drugs can be used as monotherapy in early disease. Two of these drugs are oral. One of them is given as a transdermal patch. And you can use this as monotherapy, in other words, not as an add-on therapy to carbidopa-levodopa. Most of their adverse effects are similar to levodopa, though, because just like levodopa gets converted to dopamine and activates dopamine receptors in the brain, these drugs activate dopamine receptors in the brain. So you can see things like nausea and vomiting, sleepiness, orthostatic hypotension, confusion, and hallucinations. You will hear these drugs referred to as non-ergot dopamine agonists. So why do they get this name? Well, there are an older class of drugs that were sometimes used in the remote past for Parkinson's disease called ergot alkaloids. These drugs were derived from ergot fungi. Drugs in this group included bromocriptine, pergolide, and cabergoline. These are rarely used today except for some special niche circumstances. But decades ago, people found that these ergot drugs were very effective in Parkinson's disease because they activated dopamine receptors. Their big problem, though, was that they also activated serotonin receptors. And when this occurred, patients tended to develop fibrosis. I know that sounds strange, but there are serotonin receptors that can drive production of fibrous tissue. So patients who took these old ergot alkaloid drugs would develop heart valve fibrosis, and they would get valvular stenosis. They would also develop retroperitoneal fibrosis and pulmonary fibrosis. And so these effects, which were often life-threatening, limited the use of these older ergot alkaloid drugs. So for this reason, these new drugs shown here were derived from this older class. They are called non-ergot drugs. They have less serotonin receptor activation, and therefore there's a much lower risk of cardiac valve and other types of fibrosis. You should be aware that the dopamine agonists are the preferred drugs in younger patients with Parkinson's disease. So it's not common, but some patients younger than 60 in their 40s or 50s can develop Parkinson's disease, and these patients are often treated with these drugs first instead of with carbidopa-levodopa like we do for older patients. The reason for this is because younger brains are more sensitive to dopamine levels and they are less tolerant of fluctuations. So younger patients with Parkinson's disease are more likely to develop dyskinesias, those involuntary writhing movements we talked about earlier. They're also more likely to develop motor fluctuations, meaning the on-off phenomenon. And so the dopamine agonist drugs, these three drugs listed here, are long-acting drugs. They rarely cause dyskinesia, and they are much more effective in younger patients compared to carbidopa-levodopa. There's a special form of Parkinson's disease called tremor-dominant Parkinson. This is basically a subtype of patients who have a symptomatic tremor. That's why it's called tremor-dominant, but they don't have significant bradykinesia or rigidity or gait problems. And in general, these patients have a better prognosis than patients with other forms of Parkinson's disease where there's lots of bradykinesia and rigidity. And there are two special treatments for Parkinson's disease that are particularly good at treating the tremor that are sometimes used in tremor-dominant patients. And those two meds are trihexylphenadil and benztropine. Both of these drugs are M1 muscarinic acetylcholine receptor antagonists, so they block the effects of acetylcholine. And it turns out that in the brain, acetylcholine opposes the actions of dopamine. So by blocking acetylcholine receptors, you get more dopamine activity. And that turns out to be particularly helpful for patients who have major issues with tremor. And that's where these two drugs come in treating patients with problems related to tremor. The side effects of these drugs are all the side effects that you get when you block muscarinic receptors that are important to the parasympathetic nervous system. I talk about these things in other videos, but these are things like sedation and dry mouth. Blocking acetylcholine receptors can also cause confusion in the elderly, so these drugs are often used in younger Parkinson's patients. And then one final drug we'll discuss that can be used to treat Parkinson's disease is amantadine. So amantadine is an antiviral drug, and decades ago it was used to treat influenza, although it's no longer used for this purpose. But it does have multiple effects that are beneficial in Parkinson's disease, and that's why it's still sometimes used as an add-on therapy to treat patients with Parkinson's. Some of the things it's been shown to do are increase dopamine release from neurons, inhibit dopamine reuptake. It also stimulates dopamine receptors, and it even has some anticholinergic effects like we talked about in the last slide. So for all of these reasons here, this drug can be used to treat patients who have tremor-dominant Parkinson's disease. It can also be added to levodopa-carbidopa therapy for any patient with Parkinson's disease. And in terms of adverse effects, it has two unique adverse effects you just need to know for your board exams. First of all, this drug can cause peripheral edema, so patients will notice swelling around their ankles. It also can cause an unusual drug rash called livedo reticularis. That's what's shown in this image on the slide here. It kind of looks like a purple net with lines like this across the skin. This rash is benign. The reason it happens in response to amantadine therapy is not well understood, but it's a classic complication of this drug and patients will notice it. And so here's a summary slide of all the Parkinson's disease treatments that we've talked about. You can also look at that biochemistry diagram I showed earlier. It shows you how all these different drugs work to activate dopamine receptors in the central nervous system. Let me briefly mention drugs to avoid in Parkinson's disease. So remember, patients with this condition have low dopamine activity in the brain, so you need to avoid any drug that blocks dopamine receptors. There are two dopamine antagonist drugs, sometimes given for nausea and vomiting. Those drugs are metoclopramide and prochlorperazine. These are sometimes administered in the emergency room to patients who have nausea and vomiting. If a person has Parkinson's disease and they get one of these drugs, their symptoms will get much worse until the drug wears off. And then there are many antipsychotic drugs, which I talk about in the video on antipsychotic drugs that block dopamine receptors. Those also will make the symptoms of Parkinson's disease much worse. You should also be aware that there are surgical therapies for Parkinson's disease. These can be used as an alternative to drug therapy or as an adjunct to drug therapy that's not effective enough. Years ago, the surgeries essentially removed parts of the basal ganglia to improve Parkinson's disease. There were two surgeries done. One's called a pallidotomy, which is a partial ablation of the globus pallidus. The other one was called a thalamotomy, which is a partial ablation of the thalamus. These surgeries have now been replaced with deep brain stimulation. This involves inserting a device that stimulates parts of the basal ganglia, and by stimulating them, it actually makes them less active, and that's how it improves the symptoms of Parkinson's disease. There are two regions of the basal ganglia that are targets for deep brain stimulation, and it's high yield to know these for your board exams. Those two regions are the subthalamic nucleus and the internal globus pallidus. Both of these regions of the basal ganglia inhibit the thalamus, and as we talked about earlier when I reviewed this diagram here, the problem in Parkinson's disease is that the thalamus is not activating the cortex. So if you inhibit, for example, the globus pallidus internus or the subthalamic nucleus, that will free up the thalamus to activate the cortex, and that will improve the hypokinesis. And as I said, the idea here is that high-frequency deep brain stimulation suppresses neural activation in these regions of the basal ganglia, and therefore these two areas will stop inhibiting the thalamus, and the patient will have symptoms improve. And the reason this has replaced these surgeries is because deep brain stimulation is reversible and there's no destruction of tissue. Okay, I'll finish this video with one slide on Lewy body dementia, which I talk about in more detail in the videos on dementia. So as we talked about earlier, a Lewy body is a protein collection inside of neurons, and it's seen in Parkinson's disease, but it's also seen in the brain in patients who have Lewy body dementia. I told you earlier that Parkinson's disease can lead to dementia, and when this happens, the dementia develops after the movement symptoms have been present, usually for at least 1 year or more. In contrast, in Lewy body dementia, the dementia develops before or at the same time as the movement symptoms. When that happens, we call it Lewy body dementia. When the Parkinson's symptoms are around for a year or so and then the dementia develops, we call that Parkinson's disease with dementia. Probably both diseases are a continuum of the same disorder, but nevertheless, clinically, we distinguish between Parkinson's disease with dementia and Lewy body dementia. And once again, in the video on dementia, I talk about this in a lot more detail. And that concludes our module on Parkinson's disease.